Welcome, everyone. I am Stefanie Milla,
Fantastic.
the CEO and founding director of the Aesthetic and Beauty Industry Council, here with Nicky Tzimas, a new ABIC councillor. I am so excited, Nicky, to have you. Welcome.
Thank you so much, and thank you for having me. I'm equally excited. Absolutely.
Well, I'm so excited. I think a lot of people are going to know who you are, Nicky, because Nicky is the owner director of the CPD Institute, and of course, an extremely renowned institute for non-surgical cosmetic enhancements, and especially for the injectables industry. So we are super lucky to have you. And I have just got the signal from Danielle Covalia, who is our operations manager, that we are definitely live. So we're going to have a great discussion today. And of course, everyone who's tuning in is in for a bit of a wild ride, because today we are talking about the proposed new guidelines for non-surgical cosmetic enhancements released through Ahpra. And of course, there's a consultation paper out currently that is asking for submissions, and the submissions are actually due on the 1st of March. So we are coming up to the very close to the deadline here, and we wanted to go live with Nicky today because we think it's important that if you haven't yet had your say, that you use this opportunity to listen to the arguments, and then please contact us and let us know what you think and what you want us to say to represent you. Now, this is a very hot topic. Why do you think, Nicky, why do you think this is such an important topic to be discussing today?
Well, it's important because it's actually it's change. Change is about to happen, and change has needed to happen. Yeah. So the aesthetic space has been an area that's been neglected by government bodies for a very long time. We've sort of been an industry where we've been a little bit on our own. We've been very blessed and fortunate because we've had some responsible people who have actually put their hand up and have taken on that responsibility and leadership in ensuring that we have a safe industry in the space of the non-surgical space. However, with recent inquiry that's actually occurred, there's been a lot of, I suppose, inappropriate actions that have actually occurred, that have actually hit the media, and have actually highlighted that in some instances there haven't been, there hasn't been best practice, there hasn't been safe and best practice in the non-surgical and in the surgical space. So the big target was the surgical space, and the non-surgical space has also been part of that collective now. And we are in a position now where we need to think and have a look at what the recommendations or the proposals are. And I think it's our opportunity to actually unpack and have a look at what part of those propositions are favourable and what we want to take on. We also then have the opportunity to challenge some of the proposals, some of the propositions that have been put through, and have a look at how we can actually perhaps have things modified and streamlined a little bit differently.
Well said, well said. And it's a very timely topic as well. I mean, if you look at our industry, it is now thriving with many cosmetic nurses, many cosmetic injectors, and a lot of businesses in this space. So change for us is great, but regulation is needed. But over-regulation right now can affect people's livelihoods. And of course, patient safety is at the forefront of everything we do and what we want. But at the same time, we are talking about an industry that is very well in its, it's not in its infancy anymore. It's, heading towards maturity, and we're proposing changes at this kind of late stage, which some of them needed, and some of them are causing controversy. Now, obviously, we get a lot of people calling ABIC and inquiring, and we've had so much feedback, overwhelming feedback, that the industry is a little bit worried, concerned, and sometimes, even at the ABIC conference, we saw people speak out and say, we are scared, we are worried. How are you feeling the climate out there?
I think practitioners, I think my interpretation of the worry is because it's all happened very acutely, very fast, without any sort of warning and with not a lot of guidance. And I think people are feeling a little bit fearful and a little bit more so confused. Yeah. So I've certainly gone through that, and I still feel a little bit confused where you sort of stop and think, can I, can't I?
Yes.
Because it's still a little bit grey, and I think it needs a clearer interpretation, that's for sure. And in addition to that, although there's been a lot of rumble, there's been some recommendations already made by Ahpra, there's been some suggestions, and there's some rumble happening with TGA as well. So some people are sort of moving forward towards applying some of those proposed changes. Others haven't. So there's this cha-cha happening, and people are feeling a little bit confused. So clarity is certainly...
We definitely have heard people are scared, people are confused. It's really important we now dive into what is exactly causing the confusion, what is exactly causing the fear. And the very first guideline, let's jump right in. The very first guideline talks about patient assessment, talking about mental health patient assessments and putting the responsibility for pre-screening or for identifying potential mental health related issues like body dysmorphia. What do you think of the very first proposal that does talk about those particular types of screening? Do you think it's necessary? Do you think that the onus and the responsibility for that type of screening should fall and lie onto the practitioner that's actually treating cosmetic enhancements? Or do you think that there needs to be a step in between? Do you think it's even necessary?
I think it's necessary. I've always felt it was necessary, and that's putting my mental health hat on. I think that when we're talking about responsibility, it doesn't fall into the basket of one person or the practitioner. I think it's a responsibility that we need to take on a holistic approach, right through the chain, like from the very first contact. In terms of assessment, I think that as nurses, it's wise that we incorporate some key questions within our existing consultation and assessment process that will actually trigger some responses that might assist us in identifying perhaps a patient that might be vulnerable or might be at risk or inappropriate for treatment. However, I do not think it's appropriate that as nurses we actually conducting psychological assessment tools, because we're not psychologists, we're not psychiatrists, and we're put in a position where we've got information that we don't, it almost puts the patient also at risk of them being judged, them pigeonholing them. And I'm not sure that that's okay. I think having some questions within our consultation process is healthy. The onus is now put on the prescriber to actually ask the relevant questions and do some form of pre-screening. There is no onus or suggestion that we need to be using a validated screening tool, as it has been suggested and it is required for surgical space. But I think it's great that we do have validated assessment tools, psychological assessment tools available. We have the CANSAT tool. And I think what's important and great about that, and something that we haven't had in this space, is a pathway, a clear pathway. So the fact that they're suggesting identifying patients at risk of psychological concerns or problems is great. However, I also have a concern because there's a huge onus on dysmorphia. And dysmorphia is a small portion of mental health concerns and problems within our community and society. And it's not, I suppose, the be-all and end-all of what defines a vulnerable person with a mental health problem. I think, thinking about the likes of anxiety and depression, having a look at the landscape of what it's looked like and what it currently looks like since 2020 and COVID, the community has been affected. There's still collateral damage from that. People are still experiencing symptoms of anxiety and depression. And a lot of the decisions, in some cases, of people wanting to, make a change aesthetically to the face is based on a feeling, yeah, and the feeling might come from them feeling anxious or them feeling a bit down or depressed or overwhelmed and so forth. The then question then raises, is it healthy or unhealthy for them to make a decision based on the feeling and the mood that they have? So this is big, and I think that I think there definitely needs to be a review, and that dysmorphia is not the be all and end all. I think no different. And I kind of recently been using the analogy of Ozempic and people wanting to use that to modify the way they look to feel better. People also use non-surgical procedures to elevate their mood and feel better, and to empower themselves and to reclaim themselves from emotions that they've had, or life situations that they might be experiencing. So I think the way it's been portrayed is that perhaps these treatments are negative, and they're not. They're therapeutic, just like many other treatments and medications are. And I think we need to have really clear lines as to who should and shouldn't be proceeding with the more comprehensive assessments.
Gosh, you raised such a deep point. I think that honestly, you speaking, you've taken the issue back even, and sort of we've got a magnifying glass on it, but really you've taken it back to, so we can see it from a bird's eye view. Actually, throughout, I read the guidelines quite intensively, and I could see throughout the tone of the perception of the industry and the treatments are that they're not needed, that they're glamorizations, that they are something that's superficial or superlative, extra to what you need, that that they're not linked with, you know, well-being and the happiness of a person and their health, when in actual fact, over the years, we know that, you know, human beings groom themselves. We do our hair, we have haircuts, we you know, groom facial hair. If we're males, we present ourselves, our face, our external is our interface. And we know that our minds and our bodies are, you know, linked so deeply that our brains and our minds even extend. They're saying our brain now, it isn't just in our head, in our, you know, skull, it extends
Absolutely.
to our nerve pathways through our body. And to understand the deep link between your body and your mind, it's one. And so looking after one doesn't mean that you know, that it is more vain or superficial than looking after another part of your body. So looking through, I got the sense that that Ahpra possibly think that these treatments are excessive and not needed.
Not necessary.
And
Yes.
yeah, not necessary. And they are something that is probably not healthy in a way. That's the vibe that comes across, because there is a lot of, I think, catastrophizing about what we do and about the consequences of it, when the vast majority, I was speaking to one of our cosmetic nurses and one of our doctor members, and they said, look, you know, what we do is very special. And I feel like the great majority of people are extremely happy that nothing goes wrong. The vast majority of treatments are quite successful. So we're talking about a small percentage of complications which need to be addressed. Do they need to get addressed like and in line with the healthcare system that is currently, or do we need tighter restrictions than everybody else in this space just because it's cosmetic? What do you think?
Well, you know, if I backtrack, you know, the aesthetic industry has ironically been around forever. Go back to Cleopatra, go back to the 1800s. You know, they were using paraffin back then to actually augment faces. We've just evolved, and we've evolved beautifully. We've got pharmaceutical companies that have got incredible products. They're all TGA approved. We've got regulations around all of that. So the industry's evolved fairly safely. I think what we're talking about here is more so around safety. Safety is the key, yeah. So safety to the end user, which is the patient. So what's actually come through a lot of these proposed changes with Ahpra are talking about the likes of education to the patient and for the patient. They're coming, it's focusing on the clinician and the nurse injector and the level of knowledge and experience and education that they've had. We're looking at managing complications, identifying complications. But the other key thing is that because the industry has not been, I'm going to say, regulated or well regulated, is that there's misconceptions to the end user. And I think that what's happened is that consumers have perhaps not been well informed and understand that there's an element of medical application involved in the process. So it's perhaps been misinterpreted for many to think it's an extension of makeup, for example, rather than, you know, a medical procedure. So with that, I think what's happened is the marketing and the advertising that we have probably done has gotten a little bit loose. Yeah, we've glamorized, we've sexualized, we've pornified, we've done all of that to be competitive and try to actually have patients, you know, come in to see us and to, you know, grow our database and grow our businesses. And that has happened, and that's not just happened now. That's happened back when Medicare made all the changes and aesthetic and non-surgical procedures were no longer an item number. This isn't new. It's happened a long time ago, but it's just sort of amplified in its effects. And I think the inquiry with Daniel Lanza, I can say it publicly, and you know, with the music and with the I suppose the use of non-professional terminology is something that it's not a bad thing. There are some things we can improve on and be professional. Absolutely.
Okay. Well, that's a really interesting point of view. We've actually got quite a few people watching. If you have comments so far about what we've talked about body dysmorphic disorder. Do you think that the screening tool should be incorporated in our guidelines? Do you think that practitioners, nurses should be screening for body dysmorphic disorder and other mental health issues? We want to know. Put it in the comments. If you don't feel comfortable popping it in the comments, you can always send us an email at info@theabic.org.au. It's important that we hear your feedback with regards to that. And the other thing that we're talking about is informed consent. So we're moving on to, they have stipulated that additional responsibilities for this particular area, which is non-surgical, is what we're talking about. For persons under 18 years old, they have put in a guideline that says that if you are under 18 years old, that this is not an appropriate treatment for people that are underage, and that if they were going to have it, they would obviously need to be a reason for it. And of course, they have lumped in some non-inject procedures. I'm not sure if you noticed that, Nicky, but some non-surgical in cosmetic enhancements have included laser in this and a few other cosmetic practices. So do you think it should be restricted to people only over 18? What do you think, everyone? And what do you think, Nicky?
Look, if we're going to be talking about, you know, laser
and injectables, they have actually put it all together, I think.
Yeah, they've lumped it all together. And I think, you know, there's a lot of questions around that. Like with regards to the anti-wrinkle treatments and the dermal fillers, these things modify and change the face. Yeah. So if you've got a person that's just turned 18 years old, the question is, why are they wanting it? How long have they wanted it for? Why do they want to change their face? What is happening for them on an intrinsic level? And I think that, you know, there is an opportunity there to review and assess and dig a little bit deeper as to why this person is wanting to change. Because if we actually get on that bandwagon of starting facial modifications with these treatments, the questions are they financially able to sustain and continue to have these treatments? If not, then there's other risks and pathways that may occur. And if they're feeling that that they're not appropriate or they don't fit in unless they have these treatments, then I do think there is an opportunity for a referral to appropriate service. A person at the age of 18, we need to be, it is a confusing time. We know that there's a lot happening for a person who's 18. There's all of the hormonal changes, environmental, there's a lot that happens for them. But I think that's not the first choice of treatment and intervention that we should be looking at. However, when we're talking about laser, you know, a lot of young people from the age of 13, 14 and 15 are shaving their legs. Yeah. So do we shave or do we laser? What's therapeutically more beneficial. And I'm not sure that laser is an inappropriate treatment option for something like that personally. Yeah. Yeah.
It's an interesting topic, and we actually have Amber Lewison who has said 18 and over is a yes from me. Thank you for having the courage to actually pop some comments on there, because I can see that a lot of people are watching, but some people are a bit shy. Yeah, look, I think from a lot of people, because obviously ABIC represents you. So whoever's watching this, we are a body that represents the greater majority of our members. So if our members speak, we listen, and then we represent you. So our submission is based on what has come through as feedback. And I can say honestly that the 18-year-old requirement, being 18, has been something that people do agree with for the injectables part. For the laser resurfacing, if you obviously got some teenagers going through some health challenge skin health challenges. You don't want to have it where you can't actually help a teenager with their skin problems from a young age. So I do think that we've had the feedback that we've had as strongly in support of skin treatments for them, but not injectables. So
it's measuring benefit and risk. It's like what's better, Roaccutane or actually having some laser treatment?
Absolutely. And they have put a requirement in there for persons under 18 years. There must be a cooling off period for at least 7 days. So I think that's actually smart as well, because it gives the young person time to really think about it and consider it, and also discuss it with their family. I think that's really important. Another one, moving on, just before we do move on to informed consent and financial consent, because I think everybody is in agreement with this. I haven't heard of anybody who's challenged this. But just before we do move on there, does everybody realize, and this is a question for everyone out there, do you all realize that these guidelines that have come in for non-surgical actually part of a review that occurred for surgical? So the recommendations in this particular guideline proposal stemmed from the independent inquiry that was done into surgical. Are they the same? Is surgical and non-surgical, should they fall under the same category, or should we have an independent inquest and an independent research study done specifically on non-surgical? Because Ahpra's logic in this was, whilst the independent review was going on, we actually heard that there was similar concerns with non-surgical as surgical, but there was no definitive findings in this space. It was just piggybacked off the surgical. What does everyone think? If you got the courage to pop in a comments, do you think we need a new research, independent research on this, or do you agree that it should be tagged onto surgical in the meantime? Nikki, what do you think?
I think that from what I understand, I think we need to actually review who they're collaborating with. Who are they actually getting this source of information from? I think we've got some pretty incredible key leaders in the industry, and I know that they have not been involved in any of these discussions. So I think that's the number one concern that I have. Going to people who have got very little knowledge and experience in the industry is not enough. I think, we're pretty forward with identifying what's working and what's not. We've been in the game for long enough, and I think we need to be better collaborated with.
I think consultation process with bodies such as ABIC, such as CPCA, such as ASAPs, that hasn't happened. I know that for a fact because I'm in communication with them, and we are together going to meet with, and this is the wonderful thing of collaboration between associations, is that when the crunch comes, we are aligned in that we do feel that the industry needs to be consulted properly, and we have such a large membership base right now. Nikki, we're sitting on 1,800 members. We are the largest organisation in our space, and that it crosses over all sectors of the industry. So we're positioned to be able to hear you out there, what your thoughts are. We're positioned to be able to get that feedback and then relay it back, because of course our feedback is only what the industry is asking for. And
Absolutely.
so it'd be really interesting to hear what everybody thinks. Do you think we need a new research study done? So informed consent for the financial part of it, do you believe that for images, photography, financial consent, there should be a specific consent form for that is not just part of the normal consent? You do.
Absolutely. I mean, that's something that we've personally sort of developed and we've got. And I think that just like when you've got photography and consent for social media and so forth, that needs to be a separate consent to the informed consent patients actually provide for their treatments. They need to be separate. And I think also with the financial, that needs to be separate. It's not a hard thing to do. And I think it's not only, it protects us as practitioners. We've all had the situation where we've come to the end of a treatment and the patient says, oh, you didn't tell me and I didn't know and I'm not paying. So it's healthy, and I think it's a good thing to have. Yeah, for sure.
Heyo Lim, thank you so much for popping a comment in. I love it when people have the courage to say what they think, because this is an open forum, no judgment. Everybody has the right to have their own opinion, and you have a great one. Heyo said, I agree that the independent review for non-surgical intervention and guidelines is more appropriate. We all agree that surgical and non-surgical intervention are different, and surgical intervention carries more risks than non-surgical. Great comment. That was fantastic.
Thank you, Dr. Lim. That's Dr. Lim.
That's Heyo Lim. So I honestly, truly think that that statement is very powerful. It is representative of what I've been hearing in the industry and what we've all been hearing in the industry. We do want an independent review for our space. And I think you will notice that it will probably result in a lot of changes. But I think everyone agrees photography consents and financial consents are a great way to be able to safeguard the patients, of course. And there are so many more guidelines. As we're talking, I'm flicking through provision of care and treatment. So these things, there's some great things in there. So carrying over and being the primary responsible party for a person's care from the moment that you consult them to the moment that something happens and occurs. Do you think that the person that is prescribing or the person that is treating should have that ultimate responsibility, or do you think both?
You're asking me?
I am, and I'm asking everybody else too. Everyone that's listening to this, what do you think of it?
I actually think that's a collaboration for sure. Now, I think the person that's actually injecting is the person that needs to be well educated and equipped, be able to identify should there be any signs of a complication, and be able to first response, first aid, be able to actually step in and do what they need to do to manage the situation and resolve it. And in most cases, if you're able to identify it, you're able to resolve it. However, there are instances where we know there's such a variation to anatomy and things happen. And by no means does that mean that it's the injector's error or they've done something wrong. Things happen, once we penetrate the skin, as we all know, it's a guessing game where the end point of that needle goes. So in that instance, I think that absolutely for sure the prescriber, and in most cases, continues the care and is involved in should a complication occur. But this is where I think there needs to be some consideration, and a point of difference is that there's no mention of inclusivity. And by that I mean, and it's a fashionable word, but by that I mean, where do we fit into the mainstream healthcare system? Because one of the concerns that a lot of the members have had is that when there is a complication and there needs to be a referral to the mainstream healthcare system, we end up in the emergency department. There seems to be this sense of hands being put up by ED. I don't know what to do. I don't know how I go about this. And then what happens is there's finger pointing of you did this and you've caused this harm to this person. And then this punitive approach steps in where, injectors are actually reported to Ahpra and the likes. And I think this is where it's a little bit not okay. I think that Ahpra also need to perhaps consider furthering or improving knowledge and education to mainstream healthcare system, so that in the event, you know, you've got an injector and the prescriber stepping into the mainstream healthcare industry saying, hey, we've got a situation, we need to use what you've got. We need your ultrasound. We need to do this. We need to do that. To have a better collaboration and a relationship and a partnership, because at the end of the day, we're there for the end user. We're there for the patient. It's all about all of what's happening and all of what's being proposed is to ensure that we have our patient being safe, that we have safe outcomes, ethical, safe outcomes. So the only way we're going to achieve safe and ethical outcomes is if all of the practitioners and the clinicians come together, are well equipped with knowledge and education, and are working together. And this
Agreed.
them and us needs to stop, and this punitive approach needs to stop. It's not okay anymore.
I think that that's one thing that's probably the next hot topic that you brought up. I have heard that a couple of times, but nobody has articulated it as well as you have. What do you think out there? Do you, if you are providing these types of treatments, non-surgical cosmetic enhancements, do you feel that if there are any complications that you don't have the support of traditional mainstream health? I have heard that many times. I have 2 clinics, and you know, we've had some things, you know, no inclusions or occlusions or anything like that, but we've had, you know, some things go a little bit awry with regards to the patient health on the table. A seizure or something like that can happen, and it doesn't even need to be because of the injectable procedure. But once they find out that no, you were there, it happened at a cosmetic clinic, all of a sudden there's this vilifying of the situation, of vilifying of the cosmetic procedure and of the practitioner. Absolutely, there are some hospitals that do it. I know in Melbourne that are more open to it and are more work with cosmetic surgeons, that so they're aware of these things. But inclusivity in terms of that regard, I think is a really hot topic we should talk about. We should talk about that on a live one day. Churchill Aesthetics. If you're out there, thank you so much for responding. I love that you're all getting involved in this. Please tell us what you think, because we need to know and we need to represent you. Could not agree more. Why was there no consultation sought with the industry leaders about non-surgical treatments? Get a valid insight into what patients are seen, requesting what treatment and for what reasons, instead of starting from the worst case and based on surgical complications, apply general restrictions on everything. Do we have to apply general restrictions on everything? I mean, this is so important, and this is Churchill Aesthetics. So obviously they are in the industry, they are doing this every day, and they also feel that no, we need our own independent review because we are specialized, and that is so true. And then, you know, there's another thing, complications. There's a whole section about complications in this paper that's basically stipulating that at the time you are providing this service, you need to raise with the patient in front of you. If you are not happy, you have the right to complain to this body, basically the Healthcare Complaints Commission, the Nursing and Midwifery Board, so Ahpra, and the Health Ombudsman. So you need to take the time to sit down. There are a lot of requirements now that you need to be able to talk about to your patients, a lot of information. One of them is you need to provide them those 3 places to make a complaint if they're not happy. What do you think about sitting down with a patient and saying, before a treatment's even happened, if you're not happy with the treatment that I give you, you have a right to complain to the Healthcare Complaints Commission? What do you think of that particular interesting requirement they slid in there?
I've included it in all of my post-care information, but I actually have a transparent personally, you know, with patients. And I said, look, if you're unhappy, here's our phone number. Call us. Most of anything that you're not
here's my phone number. Call me first, and I'll help you.
Yeah, but I think, you know, we've done so well as an industry. We've got some amazing bodies. Like AMAT's fantastic. You know, if there's a complication, their first response. Yeah. So, why can't we include that? You know, because one of the risks that we have as clinicians is patient disclosure. And that is that they may not come to see us. And this is what AHPRA needs to consider. And this happens across the board in the healthcare system. And we've got a lot of things that we need to consider. We've got patient literacy. We've got, how much of it have they understood, even though they've nodded? And also in terms of, it happens if something hurts or if something doesn't feel right, they may not even think to actually call you, and they'll go straight to emergency department. So I think there needs to be something a little bit in between there. No different to, if you do go to the hospital and you're discharged and you've got a whole heap of phone numbers, quite often people will go straight to emergency, to manage their so I think we need to be assimilated to mainstream. I think that we need to be respected for who we are and what we do, and acknowledged for how far we've come on our own. Yeah. So right now, I think what's happened is that a lot of members and people that I've spoken to feel that there is a little bit of a lot happening very fast and it doesn't feel like support. It feels like, as I said, like we're being told. And I think people are happy to embrace change. People are happy to actually work within safe parameters. But I think that also it's the way it's actually rolled out. Perhaps if it was actually segmented, it would make more sense and embraced a little bit better.
I think that I think everybody has that same feeling that, you said something interesting the other day, if this was put forward by AHPRA as a move towards excellence, a move towards elevating standards, an inclusive move that, included so much discussion, consultation, and education, I don't think the fear surrounding these guidelines would be there. I think the fear would be removed and we would be inspired to do better. But all that I keep hearing is the word punitive, and that the feeling out there is that it is a punitive approach to maybe not adhering to certain guidelines, rather than a move towards, as you called it, move towards excellence. And I think that's an important thing to consider. We have had some comments here, again, from Churchill Aesthetics, that there's only been one complication, and it wasn't even, in the time that she's had, wasn't even to do with the actual treatment itself, and that everything went extremely well with the public hospital. But she said that she'd have the same feedback as you, Nicky. And then, hey, Lim, Nicky, I agree that there's a lack of education and awareness of potential complications from cosmetic injectables in the hospital. Yes, we can inject Hyalase, but if there is a, adverse event, then basically it says here actually causes worsening occlusion. So the VO actually causes worsening occlusion. Despite that, they might need further assessment, ultrasound, antithrombotic therapy, and the like. So you've got strong agreement there from a couple of people, and no doubt everybody else watching. If you're watching out there, please pop your comments in. We actually really need to know. If you're too shy to pop them in the chat, in the comments, please email us info@theabic.org.au. We need to know. Submissions close on the 1st of March. So this is your last chance. It has been open for a while. You have been able to give us your feedback for a while. They extended it for 4 weeks, but unfortunately Friday is the deadline. So moving on to education and experience. This one is a good one. If you are an RN or a nurse practitioner, you need to, and you decide to change your scope of practice towards the non-surgical cosmetic enhancement procedures, you must undertake necessary education. It does not stipulate with an RTO. It does stipulate that you need to show competence before undertaking cosmetic procedures, or prescribing them, or carrying them out, and that you also need to now do continuous professional development in that area, which wasn't a requirement before. I think everyone's a thumbs up on this one. What do you think, Nicky?
Absolutely, of course, of course you want to have your CPD points in your scope of practice, in your area of practice. 20 points is not hard to achieve in this space. There's lots of opportunity. It's not hard at all.
So we love Ahpra for that one. We think that one's a long time coming, right?
Yeah, absolutely. That's not a problem at all. So the other question, Steph, was around I missed the first little bit. Sorry.
Oh, it was around training. You need to basically undergo training, and it doesn't stipulate whether it's an RTO training or it's non-RTO. It just says if you're going to go into this space, you need appropriate education, training, and competence in the area.
Yeah.
I think a little bit further detail in that area could probably be needed and required, because there are some guidelines that are quite loose that probably need a little bit more tightening up, a bit more explanation. What do you think?
There's been a little rumble around that, and so quite a few people have actually approached me and had, what they've actually sort of said is, I mean, they actually fit. Everyone wants to feel like they know the knowledge and the education they've received is going to position them to be able to be safe and ethical in the application of the treatments that they do. I think because the industry has grown so fast, what I'm hearing is that there's been a huge I suppose, surge in investment from the pharmaceutical companies who are happy to train and educate. And I think there needs to be something around that. I think definitely we need to have measurable outcomes. So when you do receive your training and education, it's important that you have some sort of certification, whether it's an industry endorsed or whether it's an ASPA endorsed, to validate that you have actually completed the training and education, and then you are competent or safe to actually inject. And I think that's something that insurance companies perhaps look for as well. I think that's the key bit there. You need to have foundation knowledge, yeah? You need to understand anatomy and physiology. You need to understand, of course, product knowledge. You need to understand managing complications. And I think going to an education provider who can give you all of that information to ensure that you're safe is really important. Yeah,
Wonderful.
definitely.
So jumping over to the requirement for nurse practitioners and for cosmetic nurses RNs is different to the requirements for ENs at the moment. Now, if you're an EN, the guidelines propose that you have 1 year of actual nursing before you actually even start to go into the field of cosmetic enhancements. I think that that came as a big shock to the EN community, because people were undergoing their enrolled nurse qualification so that they could go directly into cosmetic nursing. Now, this particular guideline prevents that from happening, because what you need to do now is, if you want to be an EN and you want to be a practicing EN in the space, you need to go and have that 1 year of actual, normal hospital bedside nursing, or whatever the traditional nursing element to it. And then you can go ahead and,
I think it's a bit more than that, Steph. I think then
yes,
you actually need to be working with a plastic surgeon or a derm that specifies who you can have to be working with under their direct guidance for a longer period before you can even consider going out on your own. I don't think they've
you can't go out on your own. You can work in the space though. So 1
Correct.
year, you have to go get nursing for traditional nursing for 1 year, and then you can go and work with as you're right, in the space, but with
under supervision.
With supervision for a long time. Actually, supervision is 75 hours. So you need to actually go and do, it says here, that is, they have practice in the area of a non-surgical procedures for a minimum of 450 hours over the past 5 years. That's if you actually want to meet the requirements of the medical board to actually practice. You actually have to, says where an EN has ceased practicing in the area of non-surgical cosmetic enhancements and doesn't have those requirements, they have to then go and fill out the requirements of 75 hours again. So in order to actually work with a practitioner that actually performs the procedures, 1 year first, then you can go and work with them for 5 years, 450 hours, and then you can perform the treatment. And then if you don't work in that space for a period of time, you need to then go and do your hours again. It basically, they're saying, if you want to do this, you should be an RN because it's not worth it. You may as well just do another year or year and a half, or even if it's 2 years, to become an RN and then not have those restrictions. Obviously, there is a burden on the RN to now supervise. That has come in a little while ago to supervise an EN. You must you must be supervised if you're an EN. You must have, you know, direct or indirect supervision from an RN. So if you're an ENs out there, there are so many requirements. You really need to read the guidelines properly and put in your own submission if you disagree with them.
I think all of that is around ENs moving forward. However, the existing ENs in the industry are fine to continue doing what they're doing. And, you know, when it first came out, it was a shock and quite, I think, disadvantageous and cruel, because we have some amazing ENs out there that are brilliant at what they do. And I'm glad that that change actually occurred.
Okay, so Trina Story Hollis, how are you? Thank you for watching. She's incredible. She's from education and from TAFE, the TAFE network. Love the discussion. Education across non-AHPRA practices need to fit treatment innovative enhancements, treatment demand, and align with the AQF level specific qualifications, ongoing development across a multitude of advanced medical-based line upskilling and fundamental understanding, measured and endorsed who, how much, and when is crucial. Love these comments, incredible. And she's also added the work placement experience might be completely unrelated to cosmetic, unfortunately. Okay, well, that's actually a good understanding. Thank you. We are going to move to, if you've dropped off, don't, you know, please come back, and because we're about to talk about the most controversial part. We saved the best for last, and that is advertising. Don't go anywhere if you really want to know what we can and can't do in advertising and what we all think about it. There are so many now more restrictions on how we communicate what we do to our patients. And some of that's called communication and some of that's called advertising. So many changes in the advertising space. One of them is a word which has come up often, and that is not to glamorize what we do. Okay, that is a very broad term. we want to hear from you all out there. What do you think about the word glamorization? What do you think about the fact that they are targeting music in ads, comedy? So, you know, having some fun and showing a skit about, you know, our cosmetic nurses having some fun or with patients or something like that, putting music behind, you know, some before and after images. They're saying absolutely not. We need to be clinical about it, show the before and after, be extremely factual, and not refer to certain terms that the TGA have given guidance on. Ahpra have also said, refer to the TGA requirements, which we know that the guidelines are changing with regards to the TGA. So, Nicky, let's start the discussion off. What do you think about that word glamorization?
The word glamorization, I was actually going to say I'm confused because of the TGA and the AHPRA contradictions, but we'll get there.
Yes.
The word glamorization, well, gee, I don't know, guys. I just, yeah, look, it's a tricky one. I mean, it's a glamorous industry, and we're here to actually make improvements. So I think showing before and after shots is certainly, you can look at that as a form of glamorization too. I think what they actually, I suppose, are more referring to is the photoshopping, the modifying the images. I think that's where the music comes in, because let's face it, music actually evokes an emotion. It changes and shifts things. And I think what they're trying to do there is, let's just call it for what it is, show your before and after shots, make sure that photography is professional and accurate, and call it what it is. And I think that's where the move is. What do I think about it? I think it's actually made things a little bit tricky. The way we market ourselves and advertise feels like there's been quite a restriction. And I think many people are actually feeling confused, restricted, and they feel like it's actually affected their flow and opportunity. Yeah.
I've heard, oh no, we need to go back and change. And this is obviously in response to the TGA, and obviously TGA and AHPRA are two different bodies. Let's not intertwine them to the point where, you know, they're saying the same thing, because they're actually not in all cases saying the same thing. But AHPRA does refer to the TGA, as in part of their guidelines is you need to follow the TGA guidelines, right? So that's part of their guidelines. And of course, they've just released a letter saying that you are no longer able to use, or soon anyway, it's going to take effect, no longer able to use the terminology dermal filler and anti-wrinkle injection, along with a whole slew of other, you know, no-nos that we can't say. There are also a whole bunch of no-nos that you can't say in the AHPRA listing too, like a glow from within. You can't say a glow from within. You can't say looking refreshed. You can't say safe, effective, quick. You can't say all those things. If you haven't read up on what you cannot say, the list is exhaustive of what you cannot say. They haven't really specified what you can say. So that is a bit of a sticking point for people. What do you think about the TGA and AHPRA conflict there with regards to terminology?
I think there's massive contradictions, and I think what people are actually sort of saying is that the two bodies appear to not be communicating. You know, we know with TGA we can't use the word Botox, Dysport, Allergan. We can't use those words. Now we're actually told we can't use the word dermal filler, anti-wrinkle treatment. But in the same breath, we need to be authentic and transparent to our patients as part of our advertising, and informing them what it is that we're actually advertising and what it is that we're actually going to be doing. So I think we're actually positioned to perhaps be not transparent with our patients. So therefore, we could also then be in a bit of hot water with our patients saying, well, she said that it's going to actually, you know, help with my lines. What is that? Is that anti-wrinkle? Is that dermal filler? Is that laser treatment? Is that a peel? What is it? So the fact that we can't be descriptive, we can't be clear with what it is that we're talking about is not okay. And that's what many are saying. Yeah.
You know, the interesting thing is, Nicky, we have had calls not just from our industry, but of clients of the industry saying, what's going on? It feels like a mess over there. I'm feeling I'm feeling a bit uneasy and apprehensive. Are they really going to take away our ability to research these treatments in Australia? And then the doorway opened up to, oh my goodness, well, if they are taking away the ability to research safe, ethical practitioners in Australia, where are they getting their information from? That's going to be overseas, because of course there is no restriction in Australia. We do not ban overseas information over Google, over search engines, over, you know, social media. So we have this extreme ban in Australia, but the patients are not being safeguarded because they're getting information from other countries where some places they don't really have much regulation at all. So they're not even getting good, safe information now. They're getting information from overseas that could be considered a little bit, you know, I suppose, a little bit more adventurous than what we do, a little bit more avant-garde, a little bit more out there. Tell us, what do you think about that? And everybody out there who's listening, what do you think about the fact that patients can research anything that they want overseas, but they cannot hear it directly from you?
Yeah. And that's another point where people have come back and said that's why that punitive feeling has come in terms of, you know, the way they're actually wanting to, I suppose, manage and control the Australian nurses or the healthcare industry. Now, it goes a little bit further than that. So it's fine that they're actually going to be seeing social media and marketing from all the other countries, but patients are actually now taking the next step. They're actually going overseas to actually receive these treatments. So I was actually speaking with clinicians in WA who were so close to Bali, and it's cheaper for patients to actually just go there and have what they need to have done. The enticement is actually happening from social media and marketing from abroad. And, you know, if we're talking about end user and safety, how is AHPRA going to manage that and control that? Because at the end of the day, if they do go overseas, standards of practice are different. And we know that we have patients coming back with complications that end up in our basket. And then, of course, the last person to touch the patient is the person that's responsible and accountable for the care of that patient. So it's a little bit of a big and a funny one. And I just want to do a little bit of a rewind with regards to the education as well. We have some incredible, and I'm not just saying I'm in the education space and I love it, but we have a lot of other amazing education bodies out there, and who put their hand up to actually make a difference for the industry. It'll be really lovely if the current Australian education bodies are supported more from Ahpra. And my question is, why are we having international education providers coming in, teaching our injectors how to inject when their level of standard is nowhere near the way we actually practice? So that's another thing that needs to be perhaps considered. So going back to the advertising, I'm really interested to hear what the audience have to say, because this is probably one of the biggest ones, I would say, that we need to really have our say on, because this is potentially going to be the make or break of how we're able to run our businesses and the impact that it's going to
I
have.
absolutely agree. It's overwhelming. We actually have Churchill Aesthetics as well. Love your interaction. You're amazing. Feedback from our patients is that they like informing themselves prior to coming in to see us, and then discuss the possible options for treatment further. They appreciate the information given so that they can read up about it and ask more specific questions. Preventing us from explaining the principles of treatment in a public space leaves patients confused, anxious, and seeking advice via unsafe sources somewhere in the crazy world of the internet.
Correct.
Oh my goodness, I love you.
Absolutely.
Thank you so much for speaking your mind. You are literally embodying every single piece of feedback that we've gotten through ABIC, that it says taking away client transparency is not, and their power, taking away the power of research and power of choice is not a smart thing. It is not protecting our patients. It is making one hurdle after another, because if you don't know, if you can't say the commonly used terminology, if you can't research, you are doing the old school research, which is picking up the phone, calling 20 clinics to see the right one for you, hopping around doing, 20 consultations rather than having it at your fingertips. We are definitely at an age where we have so much information. Knowledge is power. Why are we taking this power away from people? We should be empowering them more to make safe choices.
Yeah, it's all part of our education. We need to be giving a lot of information, and it's really funny. We're basically asked to negate and take that all away. It's a little bit crazy. Yeah.
A little bit crazy. And then what about this insane one? I cannot believe that there is a clause saying that you cannot offer other benefits with your injectables, such as spa treatments, as part of the non-surgical cosmetic procedure package. So you cannot package up or offer a complete treatment SERP plan to your client. I don't know if anyone's picked this up, but if you turn around and say, right, you need, obviously you've got maybe thin skin, or you've got pigmentation that's, affecting the way that maybe the way that your cheeks look, pigmentation is making you look a little bit more hollow. We can give you a bit of filler, but actually if we treat the pigmentation, it's going to give you that natural looking lift. You don't need as much. You've got thinning skin around your eyes. Well, let's thicken up that skin with other treatments. Before we go in and inject, let's package it up together and, give you some complimentary this or whatever. You can't do that anymore. You actually cannot offer any other benefits as part of the non-surgical cosmetic procedure package. Holistic care out the door is what I'm hearing. What do you think, Nicky?
Well, I think I'm going to say, I think a little bit tunnel vision. I mean, we're in the game of holistic approach. We're in the game of creating and treatment plans, and a treatment plan does not consist of one area of anti-wrinkle treatment or one area of dermal filler. Now, quite often, many of the members have actually spoken about doing packages, particularly in the winter. We know skin's going to be dry in the winter. So we know that if we want to actually get the patient back on track, a very baseline entry into supporting skin, I know you all know this, but I'm just getting it out, is we may do, some peels, we may do some skin needling, we might do all of that invasive stuff in the winter time to actually rejuvenate the skin. And then as a last resort, we may or may not do some dermal filler. And like you said, the rosacea is a great one. The capillaries is a good one. So I think there's a little bit of a naivety there, because we need to collaborate all of the services that we do in a treatment plan that's going to be effective to provide positive results for our patients. So that doesn't work.
Marie Coccioloni just jumped on and is watching our live. Obviously, Marie is she's a skincare extraordinaire, skincare guru. I'm sure she would have a lot to say about this, and I know she does because I've spoken with her about it. But obviously, supporting your skin journey with injectables with skincare is an absolute given. And you've taken away the power from our practitioners and from our nurses to be able to say, we are going to package this up together and we're going to give you a skincare product with this particular package, to take away that ability, because it is seen as inducement to actually get a treatment done, when in actual fact, where we look at it, it's not an inducement, it's actually helping the client to get that beautiful 360 skin. Yep, I'm here, she says, and an absolute given. Marie is the expert in this space. She actually has developed she's a creator of 3 skincare brands, two, and one is coming out, and she knows skin inside out, right? So if anybody's the expert on this particular area, it's definitely her. And, she sells to the cosmetic injectables clinics who are thriving, and their clients are thriving because of that 360 holistic approach. If somebody comes in for injectables, if I come in for, Botox around my eyes and I'm not able to be packaged up with skincare at the same time, that's only doing half of the job, right?
And it also supports the clinician to ensure that they receive they get compliance from the patient or from the it is about, it's like removing a BCC. If you package it up with an appropriate, topical application to support the treatment that's had, I mean, that is going to ensure compliance. You can have the 2 treatments separate, then it's bringing it together. Look, yeah, it's interesting, isn't it?
It's
So
a
I think
very interesting one.
there's a lot of rubble around that. There's a lot that people are saying, well, that's limiting, because people don't know what they don't know. Sometimes we need to spoon feed people in this industry. And I'm not being negative, but it's like making it easier for them to understand this goes with this and this goes with it.
One thing I think everybody agrees on, they're doing well, is basically taking away the influencer part of the marketing. So I think that's a really good move on behalf of Ahpra. Taking away the skincare part of it, or the spa treatments part of it, is not a great move. It doesn't understand, but the actual, end game, which is really helping the client's skin health, but taking away the sensationalizing, giving prizes, or you can win a free, lip treatment if you, by this certain date, if you enter, and all that type of sensationalized advertising is everybody kind of agrees with it. It's probably not, is distasteful at best, and is kind of putting pressure on the client to act right now. I really should act right now to get this discount on my skin, on my lip treatment, when really maybe they're not exactly in the right place for it, or they're still thinking about it. What do you think, Nicky?
It's interesting. I think that, we're always going to have patients that are price driven and the ones that are quality and service, driven. I think it's putting a special or a promotion on something that we deem to be medical, is probably not okay. Having a sale is probably not okay. That's happened a lot. I think that can be a form of enticement. And if we have patients that are driven by price, then, they're also the riskiest patients, or the clients as well. They're the ones that will bunny hop, and they're the ones that are probably going to, So I think that's a positive thing. I really do. I think we need to have we need to provide a service because of the service that we provide, rather than the product and the price that we provide.
There's a question from Heyo Lim. I do not understand why the TGA stops us from using anti-wrinkle and dermal filler as terms. It is because those words encourage the public to take up injectables. Does that mean we cannot use before and after photos? Sorry if I missed that earlier. No, absolutely. The TGA has put out a letter that says, remarkably, they asked us to use the terms dermal filler and anti-wrinkle instead of using, the word Botox or the word, that you can't name in advertising. You can in a journalistic sense, which is why we can talk about it and say it now, because we are being journalistic right now. We're not selling a product. But basically, you can, in the education forum, you can use those words, but the minute you sell that particular thing, you cannot now say it, which is the terminology of dermal filler and anti-wrinkle. Ahpra, along with that, are saying you also can't use the words refreshed, a glow from within, quick and easy and safe. You can't use descriptive terms like glowing skin gives you wrinkle-free face, plumped up juicy lips. You can't say any of those terms. We are struggling to understand what we can say because that is not being outlined. The TGA says you can have a consultation if you are concerned about your lines and wrinkles, and we offer consultations for that. Now, that is a very broad term, and I think that the feedback out there is, how do we know that clinic even offers injectables when that's what we want, right? So there's a transparency issue. So hey, Lim, we did talk about that earlier. Now we're talking about, and that's an extension of what we're talking about now, which is all of the guidelines that are added onto the TGA through Ahpra. And Ahpra is now saying, no, you can't use testimonials. I mean, testimonials have always been a bit not used in healthcare anyway, but you can't even so if somebody comes to your clinic and they have a procedure done, and so they have, anti-wrinkle and they show it on their feed, they're allowed to show it on their feed and talk about it. You cannot even go in and press like. If you go in and press like, you are actually breaking the rules and guidelines. You cannot comment on or facilitate a client review or testimonial. You cannot package up skincare or spa treatments with treatment. You can use before and afters, but you cannot label them dermal filler or anti-wrinkle. They need to be in the same light. They need to be in controlled environment. They need to be not touched up. I think we all agree with that. Nicky,
Absolutely.
what do you think about, those particular requirements on before and after photos?
I think there needs to be further discussion. I think we've got a little bit of a knee-jerk reactive situation with some of these proposals, and there needs to be a stronger collaboration. As I said, with key opinion leaders within the industry, they have not been consulted, and that's not feeling very reassuring when it's these people that have actually brought the industry to where it is today.
I think our clients haven't been consulted either. I think if you ask a whole bunch of clients, do you want to see before and after photos? Do you want us to speak in plain language? And this is another contradiction. The Ahpra guidelines say nurses, doctors and practitioners must speak in plain language. So plain layman's terms, you must be able to describe exactly what's happening in an understandable way for the patient. And on the other hand, they're saying you cannot use well-known terms.
You can't use dermal filler, you can't use hyaluronic acid, you can't use, it would be a lot easier if we can say, this is Botox, this is Dysport, this is, we would, because then it actually provides it says it, that is what it is, and it allows the patient to do their own research. Well, what is that? What is that? It's calling it for what it is,
So
beating around the bush.
That to me in the last 2 weeks, I cannot believe how many people have said this is ridiculous. We should actually be going the other way and being able to use the term, the actual brand name. Why can't we? Because that means the patient can't have the choice of saying, I would like this particular brand because this particular brand does this and this and this. In every other industry, we have brand choice. My goodness, I know I'm able to pick up, which I use all the time, Cosmetic's Immortal Cream, because I know that brand is what I love and this is what I use on my skin as a moisturizer. but I'm not, but if I was a client that didn't know about moisturizers, I would not be able to research the brand. That's insanity. Like, I absolutely agree. I think we should go the other way and give clients the power, the information, in a way that says here, that we need to give patients dignity, respect, and we need to make it understandable for them. Are we taking that away in the pre-learning phase, in the learning phase at the very beginning? Are we taking that away? Are we stripping that ability for them? What do you think?
Absolutely, I do think we are. I think that you've got a mix of patients that are coming in, or clients, ones that are well versed and have had plenty of treatments and they know what they want. So they're shopping, or doctor shopping, they're shopping, they know what they want. But you do have many patients that are coming in for the first time, or they're new to the space, and there's always this misinterpretation and there's always this communication barrier that tends to happen, particularly with the non-surgical treatments. Quite often I have people today still that don't know the difference between what a dermal filler can do and what an anti-wrinkle filler can do. So I think if we're going to be authentic, then position us to be able to call it what it is. Let's go back to the foundations. Let's be real the whole way, and it'll really make things a lot easier the whole way.
So the general consensus as we wrap up is that there is some great information, some wonderful guidelines in the Ahpra proposals. We have seen some really good ones about, qualifications, about titles, about education, about informed consent, all of those things, removing the social media and ambassadors from the whole equation, and dignifying the advertising or the promotion of, or the communication of these procedures. I think we need to bring that in. I think we need education. We agree with half of what they're saying, maybe even more. There are certain areas where they need more consultation. And what has come out of this is that we want an independent review based on non-surgical. It is too soon, I think, and I think everybody, on behalf of our members, this is what they have actually said, the great majority. It's too soon to make judgment calls and to ratify any decisions when it comes to the proposals. We need to vote basically status quo remains until further consultation can happen, and that's what ABIC is going to do on behalf of everyone. We're putting in the submission, and most of those are going to be the selection retain the status quo until further consultation has been had with clients and an independent review has been undertaken. Nicky, do you have any final comments?
Thank you, Steph. There's only one other thing that I want to touch on, and that is the, again, going back to acknowledgement and respect of our disciplines, is nurse practitioners. Okay, they're advanced practice, and I think that that also needs to be reviewed within this space.
Absolutely.
That's such a missed opportunity. And again, I think it's something that's not understood and respected and shut down. And just as this industry has been shut down and ignored for the last 15, 20 years, and now something terrible happens and, we're here today, I think it would be good if we can just open that door and make something good of it. Like, change should be all about positivity and for the greater good. Yeah. And I think, I think we need to be working a lot better and more collaboratively, not
Definitely. I was
us.
actually speaking to one of my nurses today who who did 5 years of clinical nursing so that she could apply to be a nurse practitioner, only to now go, okay, well, I didn't waste 5 years. It was 5 years of experience. She can do her master's, but she can't become a nurse practitioner because for the last 5 years, you have to be current, because she did 5 years and then she moved to cosmetic. She can't now do that. She has to go back to do clinical to do her nurse practitioner. You can't be just in the cosmetic space, apparently, and apply to be a nurse practitioner, even if you had your 5 years clinical in this particular specialization. I think there's a conversation to be had there.
Massive, absolutely.
Huge. All right. Well, I just want to say thank you. There are a few more comments here, which are amazing. Churchill Aesthetics, again, thank you so much for participating, everyone. It's been really great. Our patients need to be well informed. Don't treat them like they are naive, dumb, and don't have the capacity to make well-informed decisions. Beautifully
I
said.
love it.
Marie, one of our councillors, seriously, like, business isn't challenging enough. And you know what? You said it, sister. At the moment, business is challenging enough. Now they're encouraging the industry to speak in riddles. We need to be clear in our communication and not be confusing to our clients. I love that comment. Nikki, thank you so much. Stay tuned, everyone, because we will have more on this in the coming weeks. But for now, have a beautiful night. Thanks, Nikki. Thanks, everyone, for watching.
Thank you, everyone. Bye.
Bye.